fill people in on the blanks when we get started. Good afternoon, everyone. I'm Chris Murphy. I work with Styker Neurovascular. I want to thank Sandy for having me in this afternoon to offer educational content on stroke awareness and screening. I've been in the stroke marketplace for a little over 6 years. The majority of that time I was a sales representative with another company. I recently joined Styker about 5 months ago in what's called our commercial therapies role. I've taken a step away from the sales capacity and working more in education, clinical development, new business development. As I mentioned to Sandy earlier this afternoon when we were talking, our goal is to help educate nursing, ED, neurology, any of the pathways that affect stroke patients and the pathways getting to the hospital and getting treatment within the hospital. So that's kind of in a nutshell of what my role encompasses. Today we're going to spend a half hour, 35 minutes talking about stroke awareness and screening. Fiedler is a company we collaborate with to offer you credits here. Some of the learning objectives of what we're going to discuss. The incidence of stroke. We're going to differentiate the different types of stroke. The demographics of patients at risk for stroke. Thank you. The signs and symptoms of stroke. We'll talk about some basic neurovascular anatomy. We're going to differentiate the signs and symptoms of anterior and posterior circulation strokes. We're going to talk about some of the recommended guidelines for stroke screening. We'll discuss the NIH stroke scale, and we'll talk about some inclusion-exclusion criteria for TPA. Although I mentioned to the last group that came through, just about 3 weeks ago, the American Heart issued some guidelines for some changes. Perhaps you can speak to those. I didn't know, but yeah, the American Heart changed some of the guidelines, so they've reduced some of the exclusion criteria for patients that are eligible for IV TPA, which is great. That means more patients now can get it. I will get a revision soon to Sandy so she can disseminate that. I'm sure it's available on the American Heart Stroke Guidelines site as well. So I'll start out with stroke incidence. These slides are dated 2012. There was just 2014 data released. The data points haven't changed much. Stroke still remains the here's a booklet, the fifth largest cause of death in the United States. Almost 800,000 patients on an annual basis will have an ischemic stroke. That's one patient every 40 seconds. If you look at the map, the darker purple areas indicate areas of the country where stroke is more prevalent. Many of you may have heard of the stroke belt, which exists down in the southern portion of our country. Probably more strokes, more patients are affected by ischemic stroke in that area than any other portion of the country in whole. And the thought is,
Is there any reason for that?
Yeah, I was just going to mention that, right? So they feel that it's diet primarily. There's been some studies. High incidence of fried food, eating lots of fried fish, lots of fried foods, and basically poor lifestyle choices. High instances of smoking, poor diet choices. That's the thought over a large period of time. So generationally, that leads to a higher incidence of stroke. We're going to talk about the two different types of stroke. So on your left, an ischemic stroke, a stroke that's caused by an occlusion, by a blood clot or plaque that may be dislodged from somewhere, from the heart. An AFib patient would have a clot dislodge and land in a distal vessel in their brain. That's an ischemic stroke. The hemorrhagic stroke on your right, in this instance, it's a bursting of a blood vessel. That hemorrhagic stroke could be also caused by trauma, car accident, a fall, many other areas, many other things that could cause a hemorrhagic stroke. The prevalence of stroke, so 87% of strokes are ischemic. The plaque or the clot causing the occlusion, preventing oxygen from getting to the brain. And 13% are hemorrhagic. Of those, 10% are intracerebral, and then 3% are subarachnoid. We're going to spend the majority of our time this afternoon talking about ischemic stroke. So we're going to talk about large vessel occlusion and why that's important, what treatment options are available for that, and what treatment options are effective for large vessel stroke. So approximately 40% of strokes are considered large vessel. And what's a large vessel in that definition? It's your internal carotid artery, it's your middle cerebral artery, or your vertebral basilar artery. The large vessel occlusions have poor prognosis if left untreated, and that differs a little bit from your small vessel occlusions, which typically respond pretty well to IV TPA treatment. So your internal carotid artery, just over a 50% mortality rate. Your middle cerebral artery occlusions, if left untreated, roughly 30%. And then the posterior basilar artery, very high level of mortality at almost 90%. We talked in the earlier session about the FDA TPA guidelines. So 3.5 hours is the official guideline. Studies have suggested that 4.5 hours is an effective window of treatment. Most hospitals, and I'm assuming, Sandy, that Einstein is at that 4.5 hour window. Vast majority of hospitals are at that 4.5 hour window. The FDA indication for any of the mechanical devices that are FDA approved in the United States, that being the stent retriever type devices or an aspiration-based thrombectomy, are indicated out to 8 hours. Many physicians will push that limit, especially with basilar artery occlusions, because the untreated mortality rate is so high. So it's not uncommon, if the patient is an appropriate candidate, for 24 hours, 36 hours post-stroke event for them to initiate treatment, because if they do nothing, the incidence of mortality is so high for that patient population. We've all heard the terminology, time is brain. Very important for a patient that's diagnosed with a stroke to get triaged and, if appropriate, to get treatment. And the reason being is, if you look on the left, time frame here ranging from 1 second to an hour, the amount of neurons lost, the amount of synapses lost, the myelinated fibers lost, and the accelerated aging that occurs for an untreated stroke. Just within 1 second, the accelerated aging for a non-treated stroke patient is roughly 9 hours. Your average stroke untreated is 36 hours of accelerated aging. So you can see the importance of triaging a patient, getting them to treatment if warranted, can have a great benefit on their symptoms. So the prevalence of stroke by age and sex, obviously as the patients get older, they're more susceptible to stroke. Not a huge disparity between men and women with stroke, but this is an interesting point below there. The stroke kills more women than breast, ovarian, uterine, and cervical cancer combined. So definitely something to consider there. Race is certainly a risk factor for stroke as well. The African American population and Hispanic population at greater risk for stroke than that of the Caucasian population. But African Americans have a risk of first ever stroke that is twice that of Caucasians. TIAs, the mini strokes. Symptoms can mimic that of stroke, but oftentimes dissipate within 24 hours. Approximately 5 million Americans have been diagnosed with having had a TIA. The true prevalence is probably greater because it's oftentimes not reported. We'll talk a little bit about that in a moment. But about 10 to 17% of patients that have had a TIA within 90 days will go on to have a full-blown ischemic stroke. And within a year of having a TIA, about 12% of patients will die. So the big challenge is, okay, I'm a patient, I'm at home, I have left-sided weakness, I have blurry vision, it lasts for a few hours, then I'm fine. Well, I feel fine now, I didn't feel so great a moment ago. Do I go to the ER? Did that even happen? You might question yourself, but we realize the importance, looking at the outcomes that can occur if not treated, as to why it's important to do that. So we as a company, you folks, Sandy's group, a lot of what we do is trying to educate the public. The American Heart, American Stroke Association, doing a very good job of trying to raise awareness with that, getting that fast message out, trying to make patients and families aware of recognizing the signs and symptoms of stroke, and then going and getting appropriate treatment. We mentioned a little earlier, stroke, a leading cause of death. Latest data from Medicare, Medicaid, and World Health. Fifth leading cause of death in the United States. Heart disease still number one. Cancer still remains number two, even though this is 2012 data. Chronic lower respiratory diseases, COPD, emphysema still very high, and then other cerebrovascular diseases pretty high. But stroke accounts currently for 1 in 18 deaths in the United States. 1 death every 4 minutes can be attributed to stroke. And then right now, there are over 7 million stroke survivors living in the United States with a variety of symptoms and a variety of capabilities. So, 35% of those 7 million folks have depressive symptoms, 50% have some sort of hemiparesis or paralysis, 30% were unable to walk unassisted, and then kind of a mixed bag whether those folks can live independently versus those that are relegated to living in a nursing home or having active assistance. The cost of stroke is very high. The DRGs, or the dollars that Medicaid or Medicare will give to a hospital for treatment of stroke, is high, one of the highest in any of the disease states that your hospital would see or any hospital would see. The average reimbursement given to a hospital for a stroke patient is about $30,000. If you're in an urban academic center, it's a little higher. If you're in a more rural area, it might be a little lower, but the national average is about $30,000. Per patient, right? And the reason being is, let's say you have a relatively young patient, 60 years or so, and they come in with a stroke and they're left untreated. We looked at on the prior slide, what some of the comorbidities they might have. It's a large burden for the patient, for their caregivers, for their family. It can be very expensive. The average lifetime cost for a stroke patient is $140,000. If you're a 60-year-old patient and you don't get treatment and you have to be in a nursing home, you could live there for 20 or so years. So it's a large societal cost, a large family cost, a large struggle for many. So hospitalization costs take a big chunk out of that $48 billion and $16 billion, almost the same with lost productivity. And then rehab costs, physician costs, medication costs go into the mix there as well. We're going to talk about some of the signs and symptoms of stroke. There's a couple of booklets for you. Grab some lunch too, please. So the signs and symptoms, we talked a couple moments ago about FAST, recognizing the signs and symptoms, but numbness or weakness of the face, leg, or arm, often on one side of the body, difficulty speaking or understanding speech, blurred vision, blindness, either in one or both eyes, dizziness, confusion, loss of balance, and extreme headache. One of the pretty prevalent signs of hemorrhagic stroke, they call it a thunderclap or sentinel headache. Many patients that have had a hemorrhagic stroke often describe it as the worst headache they've ever had in their life. Not as common a symptom in ischemic stroke as some of the others up above, but definitely a pretty prevalent symptom in hemorrhagic stroke. Here are some of the things. If most of you folks work in the ED? Oh, therapy. Okay, I'm sorry. But your patients typically come into your ED if they're coming into the hospital with a stroke. So your ED nurses and physicians will see some of these mimics that can look like ischemic stroke: alcohol intoxication, migraine, epilepsy, psychogenic disorders, brain tumors, encephalitis, vertigo, hypoglycemia. This isn't all-inclusive, but some of the more prevalent elements that might look like a ischemic stroke. And then some of the risk factors for stroke. On the left, some of those that are non-modifiable. Some on the right are modifiable. So increasing age, family history of stroke, prior TIAs, a prior ischemic stroke, prior heart attacks. Some of the modifiable risk factors: high blood pressure, high cholesterol, smoking, diabetes, physical inactivity, AFib, carotid artery stenosis, and then end-stage renal disease. I'll speak briefly to the 4 areas. We're going to move a little bit into neuroanatomy now. The 4 areas of the brain, some of the symptoms and effects that might a stroke in one particular area might cause, and they differ from the different areas of the brain. So the 4 major areas of the brain are your parietal lobe, your frontal lobe, your occipital lobe, and your temporal lobe. I won't go into this in detail here, as we'll talk about it in the subsequent slides. So in your frontal lobe, if a patient has a stroke in that area, that oftentimes affects the intellect. Your impairment of memory can cause inattentiveness, can cause you having difficulty in learning new information. It can affect your movement, can cause involuntary movement, spasms, can affect your ability to produce language, to speak effectively. and also can cause psychological disorders. Someone that was vibrant and expressive before stroke, if they have a frontal lobe stroke or a stroke in the frontal lobe, it's oftentimes said that their personality is flattened, or they just become a different person, a different personality. The parietal lobe generally deals with sensations, so touch, pressure, pain, temperature. If you've had a stroke in the affected area in the parietal lobe, those are oftentimes symptoms that will present. The temporal lobe, auditory, your ability to hear, your ability to remember sounds, unable to give sounds meanings. You can hear something, but you hear a bird chirping, but you don't know what it is. Wernicke's area, language comprehension. You hear someone speaking, but you don't know what they're saying, and that also can affect short-term memory loss as well. And then the occipital lobe, primarily involved with vision. So strokes that occur in the proximal area of the brain, your basilar, your PCA, the vertebral area, oftentimes you'll see vision effect in those areas. Just briefly going over some neurovascular anatomy. We talked a little earlier about the large vessel occlusions that occur. Most of the strokes, well, 40% or so are large vessel, your ICA, your internal carotid artery, your MCA, middle cerebral artery, and then the basilar area on the proximal side. But here's your common carotid rising off your aortic arch. It bifurcates or separates into your external and your internal. So it's not uncommon for clot in an ischemic stroke to lodge in this area. Most common would be the MCA, your middle cerebral artery. The circle of Willis is the connection of the proximal and your anterior and posterior segments. I talked a little bit about some physicians, interventionalists pushing the limits a little bit on the FDA indication, especially for basilar occlusions, those that have the high mortality rates. Oftentimes, if you look 3, 4, 5 years ago, the treatment of stroke was really done on time parameter alone. Okay, we know when the patient had their stroke. If they're beyond 4.5 hours, they're no longer candidates for TPA. The FDA indication for the mechanical devices, those stent retrievers that extract clot, aspiration, is out to 8 hours. Many physicians will look at imaging as a predictor of outcome now. Putting time aside, if you have good collateralization, if you have a good intact circle of Willis, let's say you have a clot that landed in your middle cerebral artery here. If you have a nice intact circle of Willis, you're going to cross-fill, you're going to get perfusion from the opposite side of the brain, and you're generally, all other comorbidities aside, if you're a candidate for treatment, otherwise, you're predicting your outcomes are going to be better if you have good solid collateralization. So that's oftentimes looked at for stroke patients. And if they have a good intact circle of Willis, good cross-filling, they'll consider treating patients that are outside the traditional windows of treatment. Not for TPA, but for mechanical thrombectomy. The common carotid artery, talked about that a moment ago, bifurcates into the external, which has the main branches that will feed the face. The internal then rises higher and separates into the middle cerebral artery. The internal carotid is a large vessel. We talked about that in acute ischemic stroke. 30% of acute ischemic stroke lesions are in the internal carotid. It measures anywhere from 3 millimeters to 4.5 millimeters. 70% of the blood flow from the common carotid flows into the internal carotid artery. The middle cerebral artery, probably the most common landing zone, if you will, for clot in ischemic stroke, about 50% of the time.
I'm holding it. Rejoining your call.
I'm sorry.
No, not at all. About 50% of the time, a patient presents with a stroke. They will have had a middle cerebral artery stroke. A little smaller vessel, 2 millimeters up to 4 millimeters. Most physicians, mechanically anyway, will treat stroke in the lower middle cerebral arteries in the M1 and M2 divisions. As the vessel breaks off or bifurcates into different vessels, their names. So as they bifurcate once, it's M1, bifurcates for the second time, M2, and so on. M3 and M4 strokes, clot that has landed in those areas, fare pretty well with TPA. They're not very easy areas because they're small to get mechanical devices in, so you perhaps have heard the term lacunar strokes. Strokes in the small vessels typically respond well to TPA, but it's tough to get the devices out there. So most of our interventionalists that we work with will treat stroke out to these areas with the mechanical devices available. So middle cerebral arteries, again, the most common. The MCA supplies the basal ganglia, your orbital surface of your frontal lobe, and the lateral portions of your parietal and temporal lobes. The ICA bifurcates into the larger MCA and then the smaller ACA, your anterior cerebral artery. Not common for clot to land in those areas. We will sometimes see 7 to 10% of the time, as they're extracting mechanical devices, they've grasped clot and they're pulling it out because you're then restoring flow. Let's say you have a middle cerebral artery occlusion here. Either your aspiration catheter or your stent retriever that's captured the clot is being brought back. Sometimes clot you'll lose it and pieces of embolus will migrate to the ACA. Difficult to get to after that, but that's on a primary landing zone, if you will, for clot. Some of the different stroke signs and symptoms, and they differ from anterior strokes and posterior strokes, so I'll touch upon some of the symptoms here. So your internal carotid artery, the lower area, has a global effect on your MCA and ACA because you're preventing blood from getting all the way up there. So some of the signs and symptoms for ICA occlusion, because there is no left or right split there: monocular blindness, neck pain, partial Horner syndrome, which is a neurologic condition that affects the dilation of the pupil, can cause pupil or eyelid droopiness. You also can see combined MCA and ACA signs because you are occluding that area. And some of the symptoms and the signs differ whether you have a left or right occlusion. So for an MCA occlusion, on both the right and left side, you'll have body motor and sensation difficulties in the arm, aphasia. The eyes typically deviate toward the side of the occlusion. So when the patient is triaged via EMS or in the ED by your ED physicians and your neurologists, they can, before patients even imaged, they generally have an idea of whether it's an anterior or a posterior stroke and where the stroke is. Your ACA, a little different from the right and left. The one presents with anger, the other can present with anxiety, one can present with hostility, the other with depression, depending on what side the stroke is. And then lastly, rounding out the third vessel that we consider large vessel and acute ischemic stroke, excuse me, is the vertebral artery. Only 10% of strokes occur there. That's a relatively small artery ranging in size from 1 millimeter to 4 millimeters. And the vert supplies the cerebellum and posterior portion of the hemispheres in the brain. And then the basilar artery, 3 to 4, a little over 4 millimeters in size. This feeds the cerebellum pons and inner ear. That's, we talked earlier, that an occlusion in that area has a very high mortality rate. We'll talk about the PCA. So here are some of the stroke signs that differ, that are posterior related, that differ from anterior. We call them the 5 Ds: dizziness, diplopia, dysarthria, dysphagia, and dystaxia. Again, in your ED, your neurologists, your ED physicians, if they see a patient with these types of signs and they know that the patient has came in with ischemic stroke symptoms, they typically can identify without imaging that they've had a posterior stroke versus an anterior stroke. So we're going to talk a little bit about the stroke chain of survival. In subsequent slides, we'll see a little clock. The American Heart Association, ACLS, has put forward guidelines as to how quickly a patient should be moved through the system at different stages after being brought in with the diagnosis of ischemic stroke. So we're going to talk a little bit about that. Leading up to that, some of the 8 Ds, they call them, of stroke care. Detection. So we talked about a patient having TIA symptoms. Recognition of those symptoms, perhaps having their family members or yourself getting yourself to the hospital. That's very important. So dispatch, early activation, calling 911, getting EMS to get the patient, get them to the hospital quickly. Rapid EMS identification of stroke. Sandy and I spoke earlier about some of the things that you folks are doing with EMS education, making sure that they're aware of what you folks need from a pre-hospital standpoint, what information do we need? What type of data do we need so that when a patient comes to the ED, we can most effectively treat them to slow down the process. If EMS can identify data sets that are important to moving the patient through the pathway once they get to the hospital and get them to CT faster, get them to TPA faster, get them potentially to mechanical treatment faster, the patient's going to fare better. How quickly are they getting to the door? Triage to the stroke center. We just talked about data. The decision, who's going to decide what to do? It's going to be a multifunctional decision with your stroke team, with your ED physicians, with your neurologists, with your interventionalists. Are they going to be given drug? Are they within that 4.5-hour window? Are they candidates for TPA? And then, what are you going to do after the patient's been treated? Their admission to the stroke unit, and then their post-care. Pathways, the neurology and interventional community looks to what's been done in heart. For years, MI has been treated pretty rapidly, pretty effectively, and a couple reasons why that differs from stroke and heart. So the required team for a patient that comes into your ED with an MI, they have crushing chest pain. They're given all the appropriate tests when they get to the ED. Okay, they're going to have a cardiology consult. If they're found to have an occlusion, they might go right up to the cath lab and get a stent or angioplasty. If a patient has a stroke, they present to your ED. It's a little more multidisciplinary team that's going to be involved with their triage and decision for care. The stroke team might be alerted. The stroke team is a pretty large multidisciplinary team of individuals, physicians, pharmacy, neurology. You also have a neurologist, your neurointerventionalist, and your neurointensivist. So a little more involved with the treatment decision for those types of patients. I talked before about that little clock. We'll run through probably 6 more slides here of the timelines here. So ACLS, NINS, and the American Heart. Here are some of the recommended guidelines for ischemic stroke patients upon arrival to the ED, and some of the recommended timelines of triage, diagnosis, treatment that are recommended. So at 0 minutes, patient arrives to the ED, the button on the stopwatch is started. Within 10 minutes, a general assessment and patient stabilization should occur. If it's recognized that the patient's having a stroke, the stroke team should be alerted within 15 minutes. Within 25 minutes, a neurologic assessment by the stroke team and a CT scan should have been performed. Within 45 minutes, the CT that was done should have been interpreted and a treatment decision's made. Is the patient going to get IV TPA? Is the patient going to get IV TPA and be referred for a mechanical intervention? Or if they're not a candidate for IV TPA, are they going to be sent for mechanical intervention? Or, in some instances, you're not going to do anything. If you recognize that the patient has a major hemorrhage, their stroke is completed, you might move on to medical management at that point. And then lastly, at 60 minutes, if the patient is a candidate, we'll have one to initiate treatment at that point, by that point. So here's our clock up on the right at 10 minutes, general assessment and stabilization. Patient has arrived at the ED. We want to assess we want to evaluate their vital signs. We're going to give oxygen to the patient, obviously, make sure IVs have been established. Sandy, do your patients oftentimes come in via ACLS? Will your rigs start IV? Okay.
Most of them come in with
that's
IV
great.
is started.
And then you're going to do your CVCs, your blood counts, order your CT scan. This is a hyperdense MCA sign. This is not an uncommon CT that your radiologist will read. 50% of strokes are middle cerebral artery strokes, and that's exactly what we're looking at here. So our clock now is at 15 minutes. We are going to have alerted the stroke team. So people are now, if it's overnight, or starting to assemble, starting to come in. If you're here at the hospital, starting to converge on the ED and starting to make treatment decisions. As I mentioned before, to encourage EMS to call in. The whole pre-hospital routine is very important. It sounds like you folks have a good active grasp on that. And then rapid activation of the stroke team to help minimize the door to needle time if they're TPA eligible. Our clock now is ticking here at 25 minutes. At this point, we should have had a neurologic assessment and a CT scan. We're going to review the patient's history, perform a physical exam, establish time zero, if not already done, meaning when did the patient first arrive. I think what they're talking there actually is when did the patient's stroke symptoms exhibit. So one of the big challenges in the treatment of stroke right now is what we call wake-up strokes. So patient might have gone to bed at 10 p.m., they wake up at 7 a.m., and they have stroke symptoms. They have blindness, they have right-sided weakness. Did the patient have that stroke at 11 p.m. or did they have it at 4 a.m.? You don't know. So oftentimes those patients are excluded from TPA, and they'll do imaging. We talked about that Serpo-Willis. If they have good collateralization, maybe they'll be candidates for a mechanical treatment. When I say mechanical, do you folks all know what that is? I mean, there's many different methods, not many, there's a few different methods in which physicians can extract clot now. So TPA is the clot busting medication, which breaks the clot up. Mechanical intervention, there are 3 devices FDA approved in the US right now. Well, 2 of the technologies are called stent retrievers. It's actually a nitinol stent similar to a stent that we placed in the heart for an angioplasty, but it's on a wire, it's not left behind. So that would be opened up in the vessel. The clot is allowed to congeal within the cells of the stent, and then it's withdrawn. All this is done via femoral access, similar to an angioplasty in the cath lab. The other method is an aspiration-based technology. It's a catheter that's placed into the clot, hooked up to an aspiration pump, and it's literally vacuumed out, it's sucked out. And many physicians will use both of the therapies in concert with each other. They might open the stent up, put the aspiration system up, and withdraw it. So when I talk about mechanical intervention, that's what I mean, the disruption of clot via stent retriever or aspiration. Sandy will in the future set us up with that module, and we can talk about that more in depth, but I just realized I'd mentioned that a few times and wanted to make sure everyone was aware of that.
Thank you.
So, any of you folks or all of you folks initiate the stroke scale? Are you familiar with that? The NIH stroke scale is, it's the most commonly used stroke scale. I think every hospital that I've worked with in the past 6 years, that's their go-to to determine level of severity here. What the stroke scale does, it is a very accurate predictor of whether or not a patient has had a large vessel occlusion versus a smaller occlusion. If you look down at the bottom here, a stroke scale that's between 5 and 9, the team can determine with 36% positivity that the patient has had a large vessel occlusion. An NIH stroke scale between 10 and 15, it's a 44% positive predictor. And if a patient presents with a stroke scale greater than 15, according to this data, 100% of the time you can be assured that they have a large vessel occlusion. So you want to evaluate that patient at that point to see if they can go on for a mechanical thrombectomy, if they're eligible. So here are the parameters, responses and scores, some of the things we're looking at when we're giving a patient a stroke scale. And back to our clock here, we're now at 45 minutes. At this point, the guidelines suggest that an interpretation of the CT has been done, and we're going to make a treatment decision. Okay, maybe the patient's going to be a candidate for IV TPA. If they're given IV TPA, and we're going to repeat the neurologic exam to see if it has done what it was supposed to do. And if that didn't work, or if we know it's a large vessel occlusion, we might consider the patient for a consult with an interventional neuroradiologist, neurosurgeon. Talks about considering transfer. That would be more of a primary center. Fortunately, you folks have the capabilities at Montgomery and down in Philadelphia with your interventionalists to do the mechanical thrombectomies. So if the patient was a candidate, you wouldn't transfer, you could do it right here. I spoke a little earlier about some of the exclusion criteria. I don't want to go over this because this has changed. I encourage you to seek out that information. The American Heart Association, just within the past 3 or so weeks, have changed their guidelines. A lot of this exclusion criteria has gone away, which is great. That means more patients are now eligible for treatment. So it's 60 minutes now. We're at the end of our 1 hour. If the patient was a candidate for TPA, we'll want to have reviewed the benefits of TPA and the risks with the patient's family. We're going to repeat our neurologic exam. And if appropriate, we're going to do more advanced imaging to see if we need more information. And then we're going to initiate the stroke pathway if a patient's eligible to get them for mechanical thrombectomy. So we talked before about the levels of success or efficacy with TPA in your large vessels. Your internal carotid doesn't fare too well. That's a large vessel with TPA alone. Your middle cerebral artery, again, about 50% of strokes in the middle cerebral artery. Only about 30% of the time will those open up with TPA alone. As you get to the more distal or smaller vessels, they fare better with TPA treatment. So as that middle cerebral artery bifurcates or branches off to the next level, the vessel gets a little smaller. It's going to respond better to TPA, has less of a clot burden to break up. About 44% of the time that will open up. And then your vertebral artery, still, again, a little smaller, about a 31% of the time that will open up. But keep in mind, again, I'll repeat, about 40% of the ischemic strokes that will present to your ED will be large vessel strokes. All right, we're on our conclusion slide here. We talked about the different types of strokes, some of the signs and symptoms associated with those types of strokes. We talked about modifiable risk factors, encouraging patients to take on healthier lifestyles. We talked a little bit about the neuroanatomy, and we talked about the stroke chain of survival, how quickly you should move through the system. That concludes my talk. Can I answer any questions or any thoughts, comments?
I have a question.
Yes.
What is the risk of TPA outside of the time window?
So it's relatively high.
Why is that not indicated?
We
I don't
don't
know
know
if
if anybody
that
else
doesn't
answer,
dissolve.
right? The clock doesn't dissolve, it's
Right.
still gonna be there in
Right.
5 hours, so.
Sure.
Like, what research?
Yeah, well, why is it that it's not
Yeah, why
6
the
hours? Why is
Risk
it
is
4 and a
Why is
half?
it even limited?
The risk of hemorrhaging system-wide bleed is much higher. You're using a drug that's going to cause the entire body to bleed out.
Bleed out.
So you better have a really good reason why you're using it to bust a clot somewhere up here versus anywhere else in your body and then causing you to bleed out. So that
But isn't that the risk anyway?
But it's the risk versus benefit. So after
So,
the
yeah.
4.5 window, when they do
Your
all the
scale
studies,
shifts.
they
Oh,
see
so
that
it's
there's
because there's so much more damage at that point, so
Yeah.
the
your risk
benefit
for causing
benefits.
death
Will go more
is higher.
side versus
Right,
local.
and yeah, I mean, as you get beyond, I think it's more not that the drug is doing something differently, it's still breaking up clot
Right.
everywhere, right? Your risk for bleeding is there, but the ability to salvage, the salvageable brain is called penumbra. Brain, it still has some sort of oxygen in it, whereas beyond that window, that's less and less, so your risk benefit isn't there.
Yeah, and that's why we also do intra-arterial TPA, so we can widen the window a bit because it's a more directed application in TPA as opposed
What's
to
the
going
window with
kind of
that
a-
then?
4.5,
That's the
right?
4.5%, or a little longer.
like 17
Well,
hours.
Oh.
They usually look
Depends
at
on
8
the-
hours, but
the
it can be
vessel
up
it's
to 24
occluded.
hours.
Yeah.
I didn't even know we had the ability to do mechanical intervention here. I thought all our patients got sent out.
The only ones we'll send out will be a hemorrhage that needs intervention, surgical
They might need
intervention.
a surgical clip.
Right, that's the only
But Dr.
patients we'll
Brady,
send
and
out.
your other physicians here, probably for 4 years now, 3 years?
Since we opened?
No,
Not since you
not
opened.
since we opened.
That's a
At least a year and a half,
Yeah.
not quite 2 years.
Two-
Year and
oh,
a half,
is it? Okay.
Yeah.
I forgot how long ago it was that we
Yeah.
came in and, set your lab up. But I mean, for probably 8 years in Philly, Einstein, Philadelphia, they've been offering mechanical thrombectomy, two or so years here, which is great to have that
Do
capability.
we
and,
have a significant number of patients who do that, Sandy? Or has it been a small?
Once every few months, I would say.
Yeah, we
really?
might have had 5 or
Oh,
6
okay.
in the last year.
Oh, there's a segment that asks for presenter's name. My name's Chris Murphy. If you would write that for me, that would be great. Well, I appreciate everyone's time and attention. Thank you very much. Hopefully you grab some food and
Thank you, make
hopefully,
sure you
some
shot,
good
yeah,
info.
sure you
Yeah,
sign
please leave
in.
me your evaluation form. Sandy also has a sign-in sheet floating around. Yep, that's yours. You can keep the booklet and your certificate, please, and I'll take the evaluation form.